second to your right.
Welcome and bienvenidos. If you are staying on the English version of this presentation, stay put.
Las personas que desean escuchar la versión en español, por favor, elegir el idioma oprimiendo el botón en forma de círculo donde dice español en la parte inferior de la pantalla. Gracias.
Welcome again. I'm Julie Chronister. I'm one of the hosts of our webinar today. First things first, a brief audio description of myself. I'm a white cisgender woman, she, her. I'm in my early 50s. I have light brown shoulder length hair, thick black rimmed glasses. I'm wearing a black top, and my background is a picture of our project website, the name of our project, and an image of the mural on SF Student Center with Cesar Chavez and Malcolm X, and some fuzzy images of students in front of the mural. I'd also like to acknowledge that SF State's campuses in San Francisco sit on the ancestral homeland of the Ramaytush Ohlone. We further acknowledge that we work on the ancestral lands and waters of many other indigenous peoples and nations in our fieldwork in the Bay Area and around the world. We are committed to ensuring this webinar is accessible to our audiences. If at any time your access needs are not met or become not met during the webinar, please send a chat directly to our host or co-host. Access is always a work in progress, so we appreciate your comments, feedback, and support. A bit back to me, I'm a faculty member in the Department of Counseling, the Clinical Mental Health Counseling Program here at State. I'm also the primary investigator on this project. I'm working alongside my project co-investigators, Dr. Tiffany O'Shaughnessy, who is a faculty and coordinator of our marriage and family therapy program, as well as Dr. Molly Streer, who's a faculty in our school counseling program. I'd also like to thank our graduate assistant, Ro Cordova, who is working hard to stay on top of the technical issues, the chat boxes, etc., and is also a student of this project. Thank you all so much for your help getting this going. This is the second of our 10 webinars sponsored by our Equity and Justice Focused Integrated Behavioral Health Counselor Training Project, which is fully funded by the Department of Health and Human Services, Health Resources and Service Administration, and is part of an award totaling $1.9 million. A couple of additional things before we begin. If you are one of our HRSA stipend recipients, our ER students, or you are receiving continuing ed units for your attendance today, please pay close attention to the announcements provided in the chat for sign-in and evaluation links. Also, a reminder that this is a live recorded Zoom webinar. Therefore, the audience is not visible. You can't turn on your video or your audio. The chat function is available for you for comments, sharing of resources, supportive emojis, etc. In order to ask questions, please post your questions in the Q&A function. This will occur, Q&A will occur in the last 10 to 15 minutes of the webinar. So please post your questions there, and we will get to those at the end of the webinar. If we don't get to all questions, we will connect you with the presenter. So finally, it is with great pleasure that I introduce today's presenter, Samira Pingali. Samira is the Director of Behavioral Health at the Community Health Center Network, otherwise referred to as CHCN. CHCN is a partnership of 8 federally qualified health centers, also known as FQHCs or Community Health Centers, that serve over 350,000 people annually from underserved communities in the East Bay. These include such health centers as La Clinica, Asian Health Centers, Lifelong Medical Care, Native American Health Center, and West Oakland Health. Samira supports these health centers in enhancing access to behavioral health services, as well as informing policy and advocacy for community-based mental health. Samira leads strategic initiatives to integrate behavioral health within primary care, addiction services, and community resources. She's particularly passionate about increasing pediatric and adolescent access to behavioral health care with an emphasis on prevention and early intervention. Samira received her master's in public health from Columbia University, where she specialized in research design and methodology. So it is with great excitement that I would like to hand this over to our presenter today, Samira Pingali.
Thank you so much, Julie, and thank you to the whole team at SFSU for organizing this series of lectures It really is my honor to be here today alongside the rest of the amazing panelists in this series. And overall, I'm just so grateful and appreciative for all the students here today. I want to follow Julie's lead and quickly describe my appearance. I'm a female with brown skin, brown eyes, and black hair. I'm wearing a red top with a black cardigan and a yellow and turquoise necklace. And I'm using a blurred virtual background behind me. I am speaking to you all from Oakland, California, and therefore want to acknowledge the Ohlone land that I'm on. So the title of today's presentation is Public Healthcare Systems, Federally Qualified Health Centers, and Integrated Behavioral Health. Each one of these words can be a semester-long course. And so today I really just want to provide an introduction to a discussion around these topics. That being said, as Julie mentioned, please ask as many questions as you have in the Q&A function and share as many comments as you would like in the chat function, and I'll try to save as much time as possible at the end to answer any questions. Next slide, please. So because this lecture could potentially be 1 year long, I wanted to create a very specific structure and trajectory of what I'll be speaking about, starting with a bird's eye view of the system as a whole and then narrowing it. I'm only going to introduce the concept of integrated behavioral health, or IBH, at the end, because in a couple of lectures, you'll hear from a subject matter expert in this field who will do a much deeper dive of the IBH model. One note I want to make is that for the purpose of this lecture, I'll be focusing on California specifically. I like to point that out because each state, of course, has a very different landscape of what their public healthcare delivery system looks like. So I'll just be focusing on California today. And then one last note about terminology, I'll be using the term behavioral health, and that umbrella term includes both mental illness as well as substance use disorders. And there's some slides where I use the term just mental illness, and so that excludes substance use disorders. And the reason I use those terms is to align with the terminology that California uses both at the county and the state level in their care delivery system. Next slide, please. So I wanted to share with you all my first introduction to the concept of community-based and integrated health. And it came from my grandfather, who is shown here in this photo. So my grandfather was born and brought up in a small village in India in the state of Andhra Pradesh. He later became the doctor of that village. And I was lucky enough to visit him while I was growing up, and I would observe his clinic, which was really just an extension of his house. It was also next to the village temple and across the street from the village school. When he treated children, he would simultaneously discuss the health of their families or caregivers who came with them. And he didn't only treat the physical illnesses, but also discussed emotional and spiritual health. I share this because many years later, when I started working in the field of community-based health, I recognized that so much of the spirit and the goals of this work are reflected in what I saw earlier from my grandfather. And so I wanted to share two additional quick things about myself. The first is that I am not a clinician. I have a public health background, and so my work is really exploring behavioral health through a public health and a population level lens. And also, I'm not from California. I moved here about 5 years ago, and so I'm still learning every day about the communities that I work in and that I live in. Next slide, please. Next slide, please. Thank you. So because these topics can get so convoluted and intangible, I wanted to ground what we discussed today in the context of what's the most important, which is patient care. So let's start with a case study of a patient. Let's call her Priya. And Priya is a 25-year-old South Asian woman living in Alameda County. She noticed that she's been feeling pretty down lately. She's lost interest in things she normally enjoys, and she's been feeling really tired. She lives across from a therapist's office. So one day she decides to go inside and see if she can get an appointment. But she's told that the practice only takes a few select commercial insurances. And for the most part, it's private pay at around $175 an hour. Priya works a part-time job, so does not have employer-sponsored health insurance. And she makes around $17,000 a year, which qualifies her for Medi-Cal, which is California's version of Medicaid, government-sponsored insurance. So her first step in getting care is to enroll into Medi-Cal. So let's pause there with her story and talk a little bit about what the insurance landscape looks like in the United States and in California. Next slide, please. So this diagram over here in this slide is a visual of what the American healthcare system looks like. And as you can tell, this diagram reflects the complexity of the system. There are a myriad of boxes and color-coded arrows that flow between them. And if it seems overwhelming, that's on purpose, to reflect the convoluted nature of the system. In the US, healthcare delivery is typically divided into two systems. There is public financed healthcare, which is government sponsored, and then there's private financed healthcare, also known as commercial insurance, which is typically managed by your employer. The majority of healthcare in this country is managed by employer-sponsored healthcare and falls under the private side. For the purpose of this talk, I will focus on the public healthcare delivery system. Next slide, please. So now let's discuss a few highlights of the system. Public health insurance includes the safety net, which consists of programs and providers that serve people who are typically uninsured or who have low incomes. Here in California, for example, the largest safety net program is the Medicaid program, also known as Medi-Cal, which provides health insurance coverage to most legal residents earning less than 138% of the federal poverty level, which for an individual in California is a little under $18,000 annually. When it comes to the entity in charge of healthcare on the public side, the federal government provides funding for the National Medicare program, as well as the Medicaid program and the Children's Health Insurance program. However, unlike for Medicare, which is fully managed by the federal government, for Medicaid, each state has to manage and implement their own Medicaid and their own safety net programs. I point this out because when you reflect on the complexity of the American healthcare system and why it's been so difficult to fight for universal health coverage, it's in large part because of this historic tension between individualism versus government control, not only just for individual people, but for individual states as well. So the main point that I want to make here is that this system is not designed for health equity. Your access to health insurance relies primarily on your employment status and your zip code. And that's just the start of all the barriers someone has to go through to get healthcare coverage in the US. So let's dive a little deeper into the public system of care. Next slide, please. It's easy to get confused with the terminology between Medicare and Medicaid. So I wanted to touch upon the main differences between these two programs. Medicare is typically described as the universal health coverage for people 65 years of age and older. However, eligible populations under Medicare have expanded over time. And today, in addition to anyone above the age of 65, Medicare is also available for certain people with disabilities who are under the age of 65, including individuals who've received Social Security disability benefits for at least 24 months, who have end-stage renal disease, or ALS Lou Gehrig's disease. The Medicare program is fully managed by the federal government. On the other side, we have the Medicaid program, which is the public assistance program for low-income kids, pregnant people, and people with disabilities. Since the Affordable Care Act, or the ACA, or Obamacare, all healthy adults who meet low-income criteria are also eligible for Medicaid. Medicaid is funded by the federal government, but managed by each state separately. So eligibility criteria also varies by each state. And under the ACA, each state had the jurisdiction to expand their Medicaid program if they chose. As of today, 39 states, including DC, have adopted the Medicaid expansion. So now let's talk more about what Medicaid looks like. Next slide, please. There are two payment systems under Medicaid. Medicaid started originally with the fee-for-service system, which is a system in which patients can go directly to a provider or a specialist, and the state will then pay that provider directly for each service that they render. States found that this was a very expensive and ineffective model of delivering healthcare, so they began switching to a managed care model. And in this model, patients are assigned to a primary care provider or a PCP. And a referral from your PCP is required before you can go see a specialist. As of today, over 80% of Medicaid or Medi-Cal patients in California are enrolled in a managed care plan. Next slide, please. So why managed care? Why do states decide to turn towards that model? Well, the main reasons for managed care are to contain costs, to increase care coordination, to manage utilization of services, and to control for quality of care. By having your primary care provider act almost as a gatekeeper of services, the system is ensuring that people are not getting unnecessary specialty services that could otherwise be addressed in a primary care setting. We know that specialty services are what incurs the majority of costs here in the US. So by keeping most services under the primary care umbrella, that helps contain costs. Moreover, by having a managed care plan manage your healthcare services, you are more likely to have better coordination of care if you receive services across the various delivery systems, such as primary care, specialty care, and behavioral health. And the managed care plan is responsible for ensuring that the quality of care you receive is controlled for. Next slide, please. So Medi-Cal is California's version of Medicaid. Medi-Cal provides health insurance to Californians with low incomes, including about 40% of the state's children, about half of Californians with disabilities, over 1 million seniors, and about 1 in 6 working adults. In total, the program covers around 13 million Californians, nearly 1/3 of the state's population. However, it is important to note that having Medi-Cal alone does not guarantee access to healthcare services. Next slide, please. Okay, so I gave you a lot of information just now, so let's take a quick breath and let's review some key takeaways. Again, feel free to write comments in the chat or enter questions in the Q&A function. The main thing I want you to take away from this initial section is to understand that Medi-Cal is California's version of Medicaid, which is government-sponsored health insurance for families with low incomes. Today, most Medi-Cal beneficiaries are assigned to a managed care plan through a health insurance company, and the purpose of managed care is to contain costs and to improve quality of care. Medi-Cal is a huge and critically important program in California. 1 in 3 Californians rely on Medi-Cal for their healthcare coverage. Okay, so now let's turn to talking more about the healthcare delivery system and services provided under Medi-Cal. Next slide, please. So you may have noticed in most articles or pieces written about the Medi-Cal delivery system that the one recurring word to describe the landscape is fragmented. And that's because there are different entities that manage different healthcare services. I added this diagram on this slide to show you that you can have a patient or a client, and that the client may need to go through completely different delivery systems to obtain the following services you see here. So let me read them out loud. In the middle, you have your client, and that client may need to see primary care, specialty medical care, mild to moderate behavioral health, severe mental illness, substance use disorders, social determinant of health services, developmental disorder services. And don't worry yet if some of these terms don't make sense yet, we'll go through some of them. But basically what's critical to note here is that these systems might each communicate individually with the client, but they don't necessarily communicate with each other. And so that's one of the main reasons why it is so difficult and so cumbersome to receive comprehensive healthcare as a Medi-Cal beneficiary. So let's focus in on the circles pertaining to behavioral health, which I've shaded here in yellow. Next slide, please. Under Medi-Cal, the funding streams and the entities responsible for delivering behavioral health services are typically split into 3 buckets. The managed care plans are responsible for physical health, including primary care. And when I say managed care plans, I mean insurance companies. So they're responsible for physical health and also for what is considered mild to moderate behavioral health. Now, there's no specific diagnosis or threshold for what is considered mild to moderate, but typically it includes outpatient behavioral health services, medication management, psychotherapy, and services that are typically short to medium term in duration. This mild to moderate bucket appeared in 2014 with the expansion of Medi-Cal under the ACA. So part of the ACA expansion stated that managed care plans had to expand the services they offered to include mental health services, in addition to just physical health services. So the plans took on the mild to moderate benefit. However, if someone needs higher levels of behavioral health care for more severe symptoms, they fall under bucket number 2, managed by the county mental health plans. So not by the managed care plans. Each county manages what we say as SMI, or a serious mental illness. It's sometimes called severe mental illness, and sometimes called specialty mental health. So SMI is differentiated from mild to moderate in this spectrum. Again, there's no universal algorithm to differentiate these levels, but for example, county mental health plans tend to manage all inpatient and residential psychiatric services. Also services for individuals who experience psychosis, for example, or who need complex psychiatric medication management. And then there's a third bucket, which is the county drug Medi-Cal program for substance use disorder services. This is obtained through the drug Medi-Cal organized delivery system. And I'm not a subject matter expert in this third bucket, so I won't be diving deep into that today, but I am happy to refer anyone to resources or further reading about that bucket. Needless to say, the way behavioral health system is split under Medi-Cal is so far from the reality of people who utilize the system. Someone experiencing a mental illness cannot be easily classified into these separate categories. We move through levels of severity, and oftentimes we fall into more than one bucket simultaneously, which the system, as it is currently designed, does not allow for. Next slide, please. So this slide depicts another way of looking at the mental health delivery system under Medi-Cal. You see that there's an immediate bifurcation for mild to moderate services versus SMI services, with the managed care plan responsible for mild to moderate and the county responsible for SMI, or severe mental illness. Both these parties don't always talk to each other. So for example, if I get cognitive behavioral therapy, CBT, through a managed care plan provider, and then I experience a first break psychosis and I have to get inpatient care, I then have to go to a county provider or a county residential program for inpatient care. My initial CBT therapist won't necessarily be aware of that. And what further complicates matters is that the managed care plans often delegate the entire mild to moderate behavioral health service to a behavioral health organization. So you may have heard of Beacon, which is the largest managed care behavioral health organization, also known as MBHO. And the reason why these entities exist is because in 2014, when Medi-Cal stated that all managed care plans must add mild to moderate behavioral health into their scope of work, a lot of the plans did not have the infrastructure for this. And so they contracted with a separate entity to implement that benefit. So as you can imagine, this creates yet another layer of division, because now the entity who's responsible for my medical care is not necessarily the same entity as the one that's responsible for my mild to moderate behavioral health care. And those two entities don't always talk to each other. Next slide, please. So let's quickly touch upon some of the challenges of this fragmented system. And I think first and foremost, the challenge is that people are not fragmented, people are not bifurcated, but the system is. The fragmented system reduces timely, I think you can go backward, thank you. The fragmented system reduces timely access to care because now I have to go to multiple different agencies, organizations for different services, and they could be on opposite sides of the county or the city that I live in, which leads to transportation challenges. In the Medi-Cal population, for example, a lot of our clients have to rely on public transportation, but a lot of the services where they're offered are not easily accessible using public transportation. A fragmented system is especially challenging for people with dual diagnosis. Here in California, for example, approximately 500,000 Californians have a dual diagnosis of mental illness and substance use disorder. And so they have to rely on totally different systems for those two services. A fragmented system makes it really difficult to achieve cultural alignment of services because you receive care in multiple different systems with multiple different providers and care teams. It's very confusing and burdensome for families and loved ones as they try to understand the system and maneuver the system to help their loved ones. And it's also burdensome for providers and health centers because they have to chart in separate systems, there are separate billing structures, and there's no coordination or data sharing between providers to learn about the patient's whole care. So these are just some of the impacts of a fragmented system. Next slide, please. So again, key takeaways. That was a lot of information I gave you, and I know a lot of frustration, especially for me, bubbles up when we talk about this. So just to recap the main points, there are 3 delivery system entities for behavioral health within Medi-Cal. There's the managed care plans that manage mild to moderate services. There's county mental health plans that manage severe mental illness or SMI. And then there's the drug Medi-Cal program. And a fragmented system makes care less accessible, less equitable, less coordinated, and causes confusion and distress for all parties involved. Okay, next slide, please. So let's go back to our patient, Priya. Based on what we reviewed so far, Priya has had to enroll into Medi-Cal as a first step to getting behavioral health care services. She then had to be assigned to a managed care plan. In Alameda County, where she lives, there are 2 Medi-Cal managed care plans. There's Anthem Blue Cross and Alameda Alliance for Health. So let's just say Priya gets assigned to one of those plans, Alameda Alliance for Health. Well, Alliance delegates their mental health benefit to a managed care behavioral health organization. They actually delegate to Beacon. So Priya would have to familiarize herself with Beacon's network of behavioral health providers in order to get care. Her journey has more steps before she can actually get care. So let's pause there and shift our attention to look at a model of what a more comprehensive system of care looks like. Next slide, please. And that model is a federally qualified health center model. So federally qualified health centers aim to mitigate a lot of the barriers and challenges of the healthcare delivery system that we explored so far. Federally qualified health centers, or FQHCs, are community-based healthcare providers that receive funds from HRSA, which is the Health Resources and Services Administration, an agency of the U.S. Department of Health and Human Services. In order to qualify as an FQHC, organizations must meet a stringent set of requirements, including providing services to an underserved area or population, providing care on a sliding fee scale, and contracting with Medicaid and Medicare payers. FQHCs have to operate under a governing board that includes patients that they serve, and they have to provide comprehensive services, including preventative health services, dental services, and behavioral health services. FQHCs can be a variety of different organizations, including community health centers, migrant health centers, healthcare for the homeless, and health centers for residents of public housing. For the purpose of this lecture, I'll be focusing on community health centers. and I'll be using the term FQHC and community health center interchangeably. So in this slide, I also included the logos of the 8 FQHCs that comprise CHCN's network, which is the organization that I work for, as well as a map that shows where those 8 FQHCs are located around the East Bay. CHCN health centers were founded through struggles of grassroots organizers who sought to develop health services for their communities. The CHCN health centers continue to be rooted in these communities, attempting to improve access to healthcare and improve quality of healthcare to the members of their communities. Today, our clinics serve over 350,000 patients annually. Next slide, please. So I find the rise of the community health movement to be a really inspiring story. So I wanted to touch upon some key moments. I think that it's important to note that although the first official community health center started in 1965 here in the US, the concept of community-based care has roots in communities across the country long before 1965. The official movement of community health centers began with the civil rights movement in 1965, when a young doctor and civil rights activist, Jack Geiger, studied the model of community health centers in South Africa. He then helped found the US's first community health centers at Columbia Point in Boston in 1965 and in Mound Bayou in Mississippi in 1967. Today, community health centers serve as the primary medical home for more than 27 million people in approximately 10,000 rural and urban communities across the US. They all share a mission to provide affordable, comprehensive primary care to everyone, regardless of income level or insurance status. And community health centers really grew out of the demands for healthcare to be offered in the communities and in the neighborhoods that people live in. So I included 2 photos on this slide. The top photo was taken in 1982 and depicts members of the community at a health policy forum during Community Health Day in Oakland. And the bottom photo is what one of our member health centers looks like today. This is Asian Health Services located in Chinatown in downtown Oakland. Next slide, please. So to reiterate, the 4 key components that define community health centers are 1, that they're located in areas of high need, and these areas are designated as medically underserved areas or populations by the federal government. 2, that they offer a comprehensive set of services based on community needs, including medical, dental, vision, behavioral health, and linkages to social determinant of health resources. Number 3, that they're open to everyone, regardless of insurance status or ability to pay, and that they offer sliding fee scale options to low-income patients. And number 4, that they have a patient majority governing board. So at least 51% of every health center's board must be made up of patients that they serve. Next slide, please. So these next couple of slides are infographics by the National Association of Community Health Centers, or NAC, and depict who community health centers serve today. So I'm just going to point out a few main points. Health centers today serve more than 28 million patients. Most health center patients are uninsured or are publicly insured. So 46% are Medicaid beneficiaries. Most health center patients are members of racial and ethnic minority groups, so about 58%. And most health center patients have low incomes. About 68% of patients are at the federal poverty level or below. And this is not just for California, this is for all community health centers across the country. Next slide, please. This slide depicts the economic savings of FQHCs. Because these health centers offer preventative and comprehensive services under one roof, they are so critical in mitigating emergency visits and specialty medical visits, which are the services that incur the most costs in this country. Additionally, community health centers tend to hire staff and providers from the communities that they serve, and they bring enormous economic opportunities to the neighborhoods that they're in. So in general, health centers save the healthcare system about $24 billion annually. Next slide, please. One of the most important benefits of community health centers, or FQHCs, is the degree to which they're able to offer more culturally responsive services than other systems of care. We discussed some of these points already, such as the fact that by definition, FQHCs are housed in underserved communities, and that these health centers have to offer an array of comprehensive and holistic services, not just medical. One of the strengths of community health centers is that they focus on social determinants of health. So we all know that, unfortunately, we live in a society where our zip code dictates our life expectancy, and marginalized communities tend to have poorer health outcomes directly as a result of social determinants of health, such as access to healthy foods, economic stability, education, and built environments. Community health centers place as much importance in addressing these services as they do medical services. And one way they achieve this is really by forming and maintaining genuine ties to the communities that they serve and that they're located in. They have close relationships to the food banks, to the faith-based services, to housing services, and they really form a network of care for their clients. As I mentioned before, community health centers also tend to hire from the communities that they serve, and they strive to hire staff and providers that look like the patients they see. Because of the various languages spoken by patients at FQHCs, providers are hired who also speak those languages. And there's an emphasis on building up and promoting staff that are not just clinicians, but that are allied health professionals, such as community health workers, integrated behavioral health care coordinators, case managers, etc. And a lot of those roles are actually composed of people who used to be patients at the health centers. Lastly, I mentioned the composition of the board of FQHCs and that they have to include representation from patients, which helps ensure that patient voices are included in decision-making. So in this slide, I shared a few photos from our health centers, which show some of the linkages and ties they have to the communities they're in. So the top photo shows how our health centers converted all their parking lots to testing centers during COVID for anyone in the community free of charge. The bottom photo shows one of our health centers, West Oakland Health, that has a food pharmacy where patients or community members can come and get fruits and vegetables. All of our health centers help enroll clients into the Medi-Cal program if they don't have health insurance. And our health centers also participate in a lot of community events. So the photo in the bottom shows one of our health centers participating in a fight for breast cancer awareness in Oakland. Next slide, please. So again, key takeaways for this section. FQHCs are consumer-driven, patient-centered organizations that offer primary health services to underserved communities. FQHCs maintain cost efficiency by providing comprehensive and preventative services under one roof. And FQHCs address health equity and strive to offer culturally responsive care by creating close ties to the communities they serve and by emphasizing social determinants of health. Next slide, please. So let's go back to Priya's story. When we last spoke about Priya, she was enrolled in Medi-Cal and assigned a health plan. And now she's also been assigned to a community health center where she was able to meet her care team, including her primary care provider. She didn't have to take a bus or a train to the health center. It was just a few blocks walking distance from her house. But she still needs to see a therapist for her depression. So let's talk about that. Next slide, please. More and more community health centers have integrated behavioral health, or IBH. There are many different forms of integrated behavioral health, and they lie on a continuum. So for example, you can have co-location, where the behavioral health services and the medical services are offered under the same roof in the same building. You can have a coordinated care team, where your care team is composed of both medical providers and staff, as well as behavioral health providers and staff, and they all have access to view and to chart in the patient's medical record. The most developed side of integration is having a fully integrated system of care. And that's beyond any single community health center, but speaks about integration of the system as a whole. And as we discussed in this presentation, for California and for Medi-Cal, we do not have an integrated system. We have different payers for primary care and for behavioral health. And even within behavioral health, we have a bifurcated delivery system depending on level of severity. Next slide, please. So why is integrated health so important? Well, for one, it really increases the number of people who have access to behavioral health services. It's common for Medi-Cal recipients to have an established relationship with their primary care provider, or the PCP, and they tend to go to routine primary care visits. So if the health center has an integrated system, those patients can also be screened for behavioral health during their routine primary care visits. And similarly, it's common for people with severe mental illness, or SMI, to have an established relationship with their psychiatrists. And in those cases, the psychiatrist can encourage the patients to get routine primary care services in the same building. We know that people with SMI or severe mental illness die on average 20 years younger than someone without an SMI diagnosis because of physical illnesses. And so coordination and integrated care for that matter is really important. Having an integrated system allows for more preventative care and for early interventions. And since health centers are more likely to screen for behavioral health early and to link patients to immediate care. The rate of burnout for providers that treat patients in the safety net is extremely high. And there is a lot of vicarious trauma felt by primary care providers and staff. So for them, having the option to link patients to behavioral health provider in the same building, in the same care team, really makes a huge difference. Integrated care decreases stigma. And finally, our minds and bodies are not separate. So integrated care better reflects reality. Next slide, please. So let's go back to Priya again. At this point, she was assigned to a community health center and to a primary care provider. And she was also able to get an appointment with a therapist at the same health center, a therapist who has her medical information already because has access to her records and also has a relationship with Priya's primary care provider. So I share this story of Priya not only to help guide and illustrate our lecture today, but also to bring awareness to the fact that if you work at community health centers, every client you see has had to overcome all these barriers just to see you. And when they leave your office, they're back in that maze until next time they see you. So as future clinicians and people who will be working with these populations, it's important to have an understanding of these systems and of the structural barriers that patients face, because you can help advocate for change and advocate to eliminate these barriers. Next slide, please. So I know that it seems like I spewed a lot of negativity in this session, so I do want to end by just acknowledging some positive developments in the field as a result, mostly of advocacy. So I'm just going to point on a few things. The first is the Cal-AIM initiative, which you may have heard of. You'll be hearing a lot about it in the next few years. And it stands for California Advancing and Innovating Medi-Cal. It's a new proposal that provides a framework for Medi-Cal reform that really moves towards a system focused more on population health improvement and coordination of care. We discussed a little bit the payment system, such as fee-for-service, but a lot of counties now are exploring alternative payment models, including value-based payment, which offers financial incentives to providers and health centers for meeting performance measures. So really turns the focus to quality instead of quantity. In large part, thanks to COVID, there's more of an acknowledgement that telehealth services should be billable in health centers, especially for clients who are unable to travel to the health centers each time they need care. There's a growing emphasis on coordination of care and having electronic health systems that speak to each other. I think one of the greatest advancements over the past couple of years has been a more public awareness of the need to focus on culturally responsive care and equity in regards to who has access to behavioral health services. And we're seeing that the field is starting to recognize the need to expand our definition of what we consider a healthcare worker to be. We're seeing greater appreciation of health centers and of FQHCs, and that was apparent with the American Rescue Plan funding that health centers received during COVID. And this has all led to a seemingly obvious fact, but one that was undermined for so long, and that is that mental health and health equity are public health issues, and furthermore, they're public health priorities for our communities. Next slide, please. So I want to thank you all so much for listening today, and I shared my email address out. Please feel free to reach out to me if you want further information, resources. I can connect you to people who know about specific areas, or to answer any questions that we don't get to today. Julie, I think you're muted.
Samira, thank you so much. I can speak for myself. This has been such a clear layout of our system and the fragmentation and, you know, the efforts to move more towards integrated behavioral health. And I do just want to read a comment in the chat. This presentation is very helpful and digestible in one setting. Thanks, Samira, for making this information so understandable and easily to follow along. You're a great presenter, and I would fully agree. For such complicated information, this has really been laid out well. I certainly have learned a lot. This is a time for questions. So I'm going to look through the Q&A, and I think most people are really commenting that this is excellent. They want your PowerPoint. When's the recording coming up? But I wouldn't mind, you know, just throwing out a few questions that come up for me. And again, I want to remind the audience to please post your questions if you have any in the Q&A. I'm curious. I mean, integrated behavioral health seems to be the way of the future. And it has been talked about for quite a while. What is getting in the way of us getting there?
Yeah, thank you. I think a number of things. First of all, it is a cultural shift in the health center. It's something that requires leadership buy-in, and you have to have champions within the health centers to make integration possible. So I wasn't working in the network back when our health center started integrated behavioral health, but I remember hearing that there was a lot of tension between the medical side and the behavioral health side, and this idea that, oh, now we have to change our workflow and we have to screen for behavioral health when we only have 15 minutes in a primary care visit. And so it is a change, definitely. And so it takes a lot of effort, I think, on that side. Also, too, you have to have electronic health systems that are integrated. It is almost impossible to have an integrated system if your mental health providers are charting in a completely separate system than your primary care providers, and those systems don't talk to each other. And then I think what we're seeing more and more now is a workforce issue. And I think that you need to have enough behavioral health providers that you can hire to work in integrated health settings that are not, community health centers are incredible places to work, and they're very challenging too. So I think those are just some of the reasons why having integrated behavioral health is so challenging.
Thank you for diving in on that. And I just want to also acknowledge how much I appreciate you talking about the history of community health centers. I don't think that's well known, and where they emerged from and how long there has been fighting and advocacy for these community health centers, and how aligned these health centers are with the justice mission of equity and putting our patients and consumers front on the board. as providers. And so really appreciate you elaborating on that. Just going to check in to see if there's any other questions. I have a question about dual diagnosis. And I know you talked about the structure of, people with mild to moderate severity of mental health issues sort of stick with the managed care side, and those with more serious mental health or psychiatric disabilities move over to the county. And I'm wondering, and then there's the sort of the part of that system that addresses substance issues, if I understood that. And for many, this is a dual diagnosis issue. How is that work in this system? I mean, for years, it's been such a fragmented system where they've tried to separate substance abuse from severe mental illness, not to suggest that everyone it is that, but I just wondered your thoughts about that, if, this addressing dual diagnosis within the context of integrated behavioral health.
Yeah, so as of now, the payment systems are still separate, the delivery systems are still separate. However, I do think especially with the opioid crisis, a lot more integration into primary care is happening with substance use services. So for example, medication assisted treatment, or MAT, that now is actually included in our health centers under the primary care umbrella. So our primary care providers can go get what's called an X waiver and be able to prescribe buprenorphine for medication assisted treatment. And so that's really wonderful, because in the same primary care health center, you can also get services for addiction medicine. However, where it's really fragmented and where it becomes very complicated is if you need residential treatment, for example, for substance use disorders, or if you need assistance for certain substances, like we don't have a lot of services for meth here in Alameda County, for example. And so yes, we're starting to see a little bit of change. We're starting to see a little bit more of an integration. And I hope that with CalAIM, we'll see more of this integration. I would love to answer this question that came in the chat about how to help navigate all of these different systems, which is a great question and something that we're constantly trying to figure out how to do better. I think one really, really helpful area in this space is having staff that are completely dedicated to helping with the navigation process. So in our health centers, we have care coordinators, and we also have community health workers. Again, as I mentioned in the presentation, a lot of these staff are from the communities that we serve. A lot of them were patients, so they have firsthand experience with the systems, and they become part of the patient's care team. They follow up with phone calls. They even sometimes go and visit the patients, and they make sure that the patients make it to these different systems, because providers don't have information if the patient makes it to a mental health services in county or makes it to a specialty care service. And so these staff, they are so highly trained, and they are really there just alongside the patient through the patient's journey. And then the other huge way to encourage and promote integration is, again, through these systems that talk to each other. So for having in Alameda County, for example, the county developed a community health record in which you can actually see where your patient is getting care in different delivery across the different delivery areas. So that really helps you try to understand where your patient is getting care, so that you can have more of a comprehensive outlook on their care.
I apologize. I've been looking at the answered questions instead of the open questions, so I apologize. So I'm going to jump right in here. How does Medi-Cal define severe mental illness? Is it based on the diagnosis, duration, or other things?
Yeah, it's a really good question. There is no clear definition, and each county does it a little differently. So it essentially is about the severity and the impact of activities of daily living. So there are some, for example, if you need residential treatment, if you need inpatient treatment, that's kind of immediately under the SMI umbrella. If you have chronic psychosis, again, that's immediately under the SMI umbrella. But in general, it depends on the duration of treatment you need. So if you need to see a psychiatrist, or if you need to see a mental health provider a few times a week, that would probably fall under SMI. So the lines are so blurred, and that's what causes a lot of confusion and a lot of distress with the providers who don't necessarily know where the patient should get care in the system. And it causes a lot of distress with the patients, because what ends up happening is the patients have to get screened multiple times by multiple different systems. And a lot of what the patients are sharing are traumatic and triggering, and they're being asked these screening questions in multiple different systems just to get them in the appropriate level of care.
Okay, I'm going to do the firing of questions here. Do all FQHCs accept individuals without insurance? And are they all required to provide behavioral health services?
They're not all required to provide behavioral health services, because many FQHCs are still in the process of integrating behavioral health. I will say that the ones that I work with are very developed in their integration. They started integrating behavioral health about 10 years ago. So now they have really robust IBH programs. Yes, they are all required to offer services for people regardless of their ability to pay. So our FQHCs open their doors to anyone in the community.
Okay, I know you're not getting a break here. Could you speak more on the services that are available around social determinants of health?
Yes.
Great question.
So a lot of those services are actually integrated in the health center. So for example, there are food pharmacies. There's components of, for example, Bay Area Legal Aid will have certain representatives that come to the health center. We have a huge database of phone numbers and people from different community-based organizations who our providers, our care coordinators, and our health centers have had very close relationships to. So if they're seeing a patient that needs housing assistance, they know exactly who to call in that community to help. If they need someone who needs legal assistance or food or even childcare, access to diapers, we have just a database that we are constantly updating, that we know exactly who to refer patients to, and our care coordinators are really the ones that will pick up the phone with the patient and call these services and make sure that the patient gets to those services.
Okay. I'm going to jump around here. How can school-based mental health providers connect students and families to FQHCs?
Yeah, it's a great point. A lot of our FQHCs have clinic sites embedded in the schools. So I think in our 8 FQHCs, half of them have sites in the clinics, have clinic sites in the schools, and the providers actually rotate between the primary care sites in the community and the sites in the schools.
Okay.
And then there's also the schools are starting to use the same electronic health system in their clinics, so that clients who are students, but who also get care in the clinics, the schools and the clinics are able to speak to each other.
Yep. Okay. Is a community health center different from a comprehensive health center?
I'm not entirely sure. I know that a comprehensive health center, I don't think is listed under the different types of FQHCs, but I'm not entirely sure about that one.
Okay. I have to ask, what are some jobs that would be appropriate for new graduates be qualified to take on an integrated behavioral health setting?
Come work at our health centers, please. We have internships for associate level students. We hire licensed clinicians. We hire social workers, AMFTs, ASWs, psychology interns, and then psychiatrists. And now I mentioned briefly the alternative payment model and value-based payment, and I know you're going to have a lecture about that soon. Medi-Cal is starting to open the scope of who is a billable provider, because they understand there is so much need in the system right now, and there's such a shortage of workforce. So, I mean, if you are interested in learning more about our health centers or employment, reach out to me. I'm happy to talk to you and share more information.
Okay. Okay, I know we're at 12. I'm going to ask a short question. In community health centers with such high need, are patients able to receive services in a timely manner, or is there generally a long wait time?
Yeah, that's a great question. It depends on each community health center. For primary care, there tends to not be a wait time. For behavioral health at this time, unfortunately, there are starting to be wait times. So some of our health centers have wait lists of about 100 clients right now. Some of them are able to see patients more timely. I will say with telehealth, it's a lot easier to see more patients because there are fewer no-show rates. And so providers are not just waiting for their patients to come. And then, before telehealth, about 40% of patients didn't come to their appointments. So with telehealth, it's a lot easier to get more timely access to care for behavioral health.
Okay. I do want to honor that it's 12:01. I know there was some questions that weren't answered. I know there's stuff about payment reform, and we will be having our next webinar with Dina Lon. She will be talking more about that. And if you didn't get your question answered, we encourage you to email directly to Samira, if that's okay with you. And I want to just a big thank you, Samira, for this terrific presentation. There's lots of gratefulness in the chats and in the Q&A for your work and your thoroughness and the details here. So big thank you. And I suspect you'll have some emails.
Absolutely. Thank you all so much.
Okay. Thanks everyone for joining.